My research focused on preventing vitamin B12 deficiency in women of South Asian origin. And the reason that I focused on this research, there was a longitudinal study that was published from Pune in India, and the results of that study, the study looked at maternal nutrition through pregnancy, conceptually through pregnancy, and then monitored the children afterwards, and still is monitoring the children in the longitudinal study. And some of the key findings were that low maternal B12 in pregnancy was associated with changes in the genetic expression of metabolism in these children that could predispose to chronic disease in later life. This was the Pune Maternal Nutrition Study. It was undertaken at King Edward Memorial Hospital in Pune in India, where Elaine has gone and worked with the team there for a while. It was undertaken on just under 800 women were followed through, and on all aspects of nutrition. And the key finding that came out was this about maternal B12. What the team found were the babies that were born to mothers that were low in B12 were small babies, quite scrawny looking babies really, in terms of quite small with a low muscle mass, but they had a relatively high percentage of fat, and that fat was deposited as abdominal fat. And following the children through, at 6 years of age, those children that were born to mothers that were low in B12 were more insulin resistant than those that were born to B12 sufficient mothers. And the interesting thing about that is the effects were exacerbated if the mothers were low in B12 and high in folate, which was important because in India, even though there is a prevalence of B12 deficiency, the antenatal guidelines that are followed is that women are supplemented with folate in pregnancy, even though the majority follow a vegetarian diet, and folate deficiency isn't actually as common as B12 deficiency. So the conclusion was that low maternal B12 and high folate may contribute to this epidemic of adiposity and type 2 diabetes in India. And these are in addition, we already know there's risks of B12 deficiency, probably as health professionals, well-known risks of macrocytic anemia, probably not quite so well known as it's only about a third of people with B12 deficiency that present with macrocytic anemia, and that traditionally has been used as one of the key diagnostic signs for recognition of B12 deficiency. Neurological and cognitive impairments are known risks of B12 deficiency, but far more commonly associated with older adults who have an age-related malabsorption of B12. More recently, there's been a lot published about raised homocysteine levels. Homocysteine is a metabolite that is produced when there's a deficiency of either B12 or folate in the methionine synthesis pathway, and homocysteine has been associated with chronic diseases such as cardiovascular disease and hypertension, also recognised as a neurotoxin. What isn't recognised, but there is an increasing body of research on it, is that B12 deficiency is also associated with risk of neural tube defect for the fetus in pregnancy. There's a lot of publicity, and justifiably so, about neural tube defect and folate deficiency, but you don't hear much about neural tube defect and B12 deficiency. Why do we focus on women of South Asian origin? There's a predominance of vegetarian dietary practices for South Asian people. Their preferred diet is vegetarian, and even those that eat meat, the meat doesn't have the same predominance in the diet as it does in the Western eating diet. And I found that in my study in analysing the dietary patterns. Those women that eat meat would state that they are meat eaters, but they might eat meat maybe once a week, and it may just be one serving of chicken. So there is a high prevalence of B12 deficiency, and there's a number of studies published overseas, but when we were looking for here in New Zealand for an increasing number of South Asian, or increasing percentage of South Asian population here, there's not much published about B12 deficiency in New Zealand. There have been a couple of small studies undertaken by Awatea, Elang students, where the results did show that B deficiency was more common, B12 deficiency, in those that didn't need meat. We believe there's an intergenerational passing on of the B12 deficiency, so mothers are low in B12 in pregnancy, they pass on low B12 stores to their children. With vegetarian dietary practices, those B12 stores don't get topped up, and then that's passed on to subsequent generation of children. And in South Asian population, there's a very high prevalence of gestational diabetes. One in 6 pregnancies among South Asian probably will present with gestational diabetes, and there's also very high rates of type 2 diabetes mellitus and cardiovascular disease.
I'm allowed to ask you questions while you go.
Yeah, because it stops me being so nervous.
When you talk about the South Asian population, is that the South Asian population on the map, or the South Asian population in New Zealand that you're referring to?
No.
Or is it both?
I'll just get to it. It's women living in New Zealand, or in fact living in Auckland, of South Asian origin. So anyone that's originally, and it may have been 2 or 3 generations ago, from India, Sri Lanka, Maldives, Pakistan, and Bangladesh, and like Fiji and Indian, South African Indian.
So it's 1 in 6 South Asian women living in Auckland have GDM.
Present with gestational diabetes mellitus, yes. And I haven't got the figures on me, but the figures for diabetes mellitus and cardiovascular disease are also quite high. They're up there with prevalence rates alongside Maori and Pacific Island. Yeah.
So 3 in 100 European, 10 in 100 Pacific Maori, 1 in 6.
It's very high. It is of concern. So this low B12 deficiency, if that is, as the research suggests, associated with diabetes mellitus and gestational diabetes, then it is an important problem to address. This is just some other research that another big study that's come out of Mysore in India. Once again, just under 800 women were followed during pregnancy, monitoring B12 concentrations, serum B12, and looking at risk of gestational diabetes. And maternal B12 deficiency was associated with increased adiposity, insulin resistance, and a higher presentation with gestational diabetes. This research that I've undertaken, situated or underpinned by the World Health Organization theory of developmental origins of health and disease, and what we're looking at is optimising that prenatal environment. So some stress in this prenatal environment provokes adaptive changes in the metabolic and endocrine systems that are permanently programmed in the phenotype of the child that can predispose to later disease. And we think this is where the link with B12 comes in. B12 predisposes to insulin resistance in early childhood. What happens is, in response to that insulin resistance, the beta cells secrete more insulin, so there's a relative hyperinsulinemia that occurs, and so the child can compensate, keep blood glucose regulated, but in response to lifestyle factors, environmental factors, particularly our obesogenic environments these days, that genetic susceptibility just exacerbates those accumulated lifestyle risks. So what we wanted to look at was break the cycle of the intergenerational effects of low vitamin B12, increase B12 stores in women before they get pregnant, and find some effective and sustainable way of doing that. And hopefully reduce the fetal metabolic changes associated with low maternal B12 in pregnancy. The reason why B12 can be such a problem once you see the sources of B12, you can see why. B12's naturally just in foods of animal origin and fish. So it's naturally in fish, chicken, meat, eggs, milk, yogurt and cheese. A lot of the women in the study felt that because they were vegetarian, they were never ever going to eat a diet that was adequate in B12. But in fact, some of the women in the study, in the randomised controlled trial, when we analysed dietary patterns, those that had 3 or 4 servings of milk or yogurt a day had an ample supply of B12. So the vegetarian diet which we practice, it's not that it's a risk so much, it's just quantities of food that's eaten if animal products aren't consumed. Someone on a typical Western meat-eating diet, probably the recommended daily intake is 2.4 micrograms a day, and someone on a Western diet probably eats about 5 or 6 micrograms a day. So there is an ample supply in the traditional meat-eating diet. B12 is also available in fortified sources. It's in soy milk and rice milk. It's in Marmite, but not in Vegemite. So probably quite a few people in New Zealand, and some of the ladies that were in the study that I undertook, have a lower intake of B12 these days. It's also in energy drinks, which was an important source of B12 intake for some of the younger women in the study. That was really their only source of B12 intake. And it's only meal replacement.
You weren't encouraging it.
No, we weren't encouraging it. But it was the major source of B12. And which is a bit of a worry. And then meal replacements like Up and Go are fortified with B12. In terms of testing for B12, we are a bit limited here in New Zealand. We have serum B12 as the main biomarker that's used to determine B12 deficiency. The problem with that is serum B12 measures stores and circulating B12, and there are stores of B12 that are stored as haptoquinone, and we're not quite sure of the function of these stores. So serum B12 it measures that, so it's quite an indirect measure of the B12 that's available to tissues for tissue metabolism. And yet it's the test that we predominantly rely on. And what can happen is serum B12 can be normal, but there can be a cellular deficiency of B12. There are other tests available. Active B12 measures holotranscobalamin, which is a B12 that's actually delivered to tissues. It's a much better indication of cellular B12 supply. The problem is it's only available at specialist laboratory, and the specialist laboratory that's available here is at Middlemore. And then some other tests are homocysteine and methylmalonic acid. These are both metabolites that are produced in B12 deficiency. Homocysteine is also produced in folate deficiency, so it's not sensitive, totally sensitive for B12 deficiency. Methylmalonic acid is only produced in B12 deficiency. So they are useful diagnostic tests for determining B12 deficiency, but the problem is the cost. Homocysteine is about $60 per test, and methylmalonic acid is about $90 to $100 per test. For this study, we froze the samples until we had funding, and I just found out last month that we've got funding, so we can actually get our samples for this research tested now. Now, the average person stores about 4 to 5 milligrams of B12, so there's enough B12 to last for about 5 years. So if someone who had been eating meat suddenly decided to become vegan, it would take that amount of time before they started to deplete the stores. The gastrointestinal tract is very good at recycling B12, so any B12 released in the bile, if someone is developing a B12 deficiency, they become very frugal at recycling that B12 and maintaining B12 supplies.
Earlier ago you mentioned that it can change in older adulthood. So is that to do with changes in the GI tract or just slower metabolism that may affect it?
It's changes in the GI tract. What happens is people age, they tend to release less gastric acid, and B12, in order to be absorbed off food, vitamin B12 has to be cleaved off the food protein by acid hydrolysis. So when there's a lack of gastric acid, it can't be cleaved off the food, so it's not absorbed as well. We used to think that lack of intrinsic factor was the most common cause of B12 deficiency, but in fact, latterly research has shown that in older adults, the most common cause of B12 deficiency is atrophic gastritis and the lack of acid hydrolysis. that inhibits absorption rather than being a lack of intrinsic factor.
I wonder if anyone studied introducing more acidic foods into older people's diet to help them. So I suppose it's a specialised acid and I don't know enough about it. But
Well, the person sitting next to you has been studying kiwi fruit enzymes and their proteolytic effect. So I'm not sure about the relationship with B12, but
no,
yeah.
it won't affect it because the kiwi fruit works at the higher pH, and it's the
Okay.
low pH that unfolds the.
yeah.
Okay.
So not
I'm
yet.
interested in my new detail, but I am.
Okay.
So
That can be Bruce's postdoc.
Yes.
I'd just like to point out, this is a bit of a bugbear, so I'm just going to point it out, pharmacological versus physiological doses of B12 deficiency. About 8 to 10% of the population malabsorb, most likely to be older adults. And that population may require large pharmacological doses of B12. So the recommended daily intake is 2.4 micrograms. So for that population, large pharmacological doses are justified. For example, the injection that is funded by Pharmac, and it is the only funded supplement by Pharmac, is 1,000 micrograms, and it's often repeated 3 times. So if someone's B12 deficient, they generally receive 3 doses, so 3,000 micrograms, and the recommended daily intake is 2.4. It's given in New Zealand as a B12 injection because we've always given it as a B12 injection, but in fact, research for the last 15 years has supported that oral dose, high oral doses of B12 are just as effective. About 2% of the dose of B12 is absorbed by passive diffusion. So even if someone lacks intrinsic factor, they can still absorb enough of a high enough dose by passive diffusion. But when I undertook some focus groups in the community, it seemed to be that the main treatment was the 3 doses of intramuscular B12 injection for deficiency, no matter what the cause of the deficiency. For people who malabsorb B12, they are not as good at conserving their supply of B12 because they don't absorb B12 well to start with, they don't reabsorb it well and don't conserve their own stores. For people who are B12 deficient because of a dietary insufficiency, so absorption is intact, they absorb B12 well. So they require only physiological doses of B12 supplement to actually replace what they're missing in the diet really. Intrahepatic recycling of B12 is intact, so they're very good at conserving, and deficiency is not likely to be as profound. And this was the group of people I was focusing on. In our New Zealand context, our current B12 policy statements are based on the assumption that B12 deficiency is rare and that lack of intrinsic factor is the primary cause of B12 deficiency. Pharmac only fund a high-dose intramuscular B12 injection, no oral supplement, and not even the multivitamin supplement funded by Pharmac has B12 in it. The folic acid bread fortification introduced in May 2012, and the policy documents was considered safe, even though high folate levels may mask B12 deficiency and can sometimes make the neurological effects of B12 deficiency more profound. It was still considered safe because B12 deficiency was considered rare. Folic acid supplements, and justifiably so, are recommended prior to pregnancy to prevent neural tube defects, but there's no emphasis on B12 supplementation or adequate B12 status at all. And serum B12 isn't included in the routine antenatal blood tests in women in New Zealand, although talking to some midwives, if they have someone that's practices vegan or vegetarian dietary practices, then they will actually test for the B12. So this caused a few concerns because we believe that B12 deficiency may not be as rare as previously considered. Our meat and true veggie diet has changed. The New Zealand Nutrition Survey released last year showed that 24% of women aged 19 to 30 years reported an adequate intake of dietary B12. There's more people with vegetarian dietary practices for economic, religious, health-related, philosophical reasons. The widening income gap is quite a big one. We have a widening income gap in New Zealand, creating food security issues. the foods that are high in B12, the meat, the fish, the chicken, the dairy products are all expensive. And in fact, while I was undertaking this study, it looked from the food frequency questionnaire as if people's dietary intake of B12 dropped. And I did wonder whether that was the influence of the milk prices, because that was in the period that the milk price went up exponentially. And then the systematic reviews have shown that high-dose oral B12 supplements are just as effective as intramuscular at treating B12 deficiency, unless someone has inflammatory bowel disease, and then they're not likely to absorb B12 by passive diffusion. So the research questions were: how adequate is vitamin B12 status in New Zealand South Asian women of childbearing age? What are the factors that influence B12 intake? And what are effective, appropriate and sustainable ways of increasing B12 stores in South Asian women prior to becoming pregnant? This was a mixed methods community participatory study. I started out by visiting a lot of the community groups, South Asian community groups, and talking with them to find out their experience of B12 deficiency, what their concerns were, and they were really interested and really supportive. Both a lot of the health practices that enrol a large number of South Asian people were also really interested, and set up a South Asian community collaborative group, and I thought someone might be here from the group today, but they haven't turned up, to assist and guide the research. So I had 4 ladies who were very good at providing advice and at recruiting participants for me. And at answering any questions that I might have, or just guiding the whole research process. So there were 3 parts to the study. The first part was the qualitative study methods and undertook focus group discussions. The second part was the development and validation of a B12 food frequency recall questionnaire that just to estimate the B12 intake from food. Now, food frequency questionnaires, as Elaine will probably tell you, are traditionally very unreliable, but I didn't think mine was that unreliable.
It was focused.
And then a randomized controlled trial comparing 3 treatments to increase B12 intake. Now, this was a registered clinical trial with the Australasian Clinical Trials Registry. So the qualitative study was the focus group discussions. I had 6 South Asian community focus groups. What I would do is run one focus group, quickly analyse it, work out what questions I could have elaborated on a little bit better, what was a bit unknown after that focus group, and then use that information in the next focus groups to try and build a base or codes that contributed to themes to give me an idea around what was important for women in terms of B12 deficiency in our current management, what influenced their B12 intake, and also if we were going to conduct this randomised controlled trial, what was an appropriate way to conduct it. So how much time have I got? And no one's asleep yet? Oh, except my husband at the back here. He's not allowed to go to sleep. Yeah. So I ran one focus group with health professionals. They were quite hard to get together. I did want a group of midwives for a focus group, but I just could not commit them to meeting for a focus group. So in that health professional group, there was a couple of GPs, health promoter, practice nurse, and 2 dietitians. Two groups of young mothers, so mothers with young children, and then in response to some of the information I've received about mothers and mother-in-laws being quite a big influence on dietary practices for South Asian women, I ran a very interesting focus group with older generation members, and then a focus group with young professional women, and another group with South Asian community workers. So all of these interviews were taped and transcribed, and I used thematic analysis, phrase by phrase thematic analysis. Quite a lot of findings, so I've just summarised the main findings. The key one was that B12 deficiency was common. In these focus groups, there would probably be about half of the women that had B12 deficiency at some stage, and the majority of those were treated with injections. The interesting thing was the B12 deficiency had been quite prolonged over a number of years, but the women were still a lot of the time unable to state the reason for their B12 deficiency. Some didn't make the link to vegetarian dietary practices, others did, but didn't make the link to increasing their dietary intake of foods. There was a number of women talked about trying to find more information on B12 deficiency, but didn't get the answers that they were looking for. So there was a lot of searching for reasons for B12 deficiency. One of the other big things to come through, was vegetarianism. Being vegetarian was really important. It was part of their identity, it was part of their family identity, it was part of their cultural identity. It was non-negotiable. So there was no way, even with B12 deficiency, and a lot of them were also iron deficient, that they would consider changing those dietary practices. It was just part of who they were. And along with that, the women complained about the lack of specific resources on food for vegetarian. Like if they wanted to find something about iron content or B12 content of foods for people who were vegetarian, they had to wade through all the information on meat sources of B12, which is philosophically for some of them not that comfortable before they get to the 2 or 3 sentences at the bottom of the information. So they wanted more resources on B12 foods, vegetarian specific resources, and they specifically wanted more choices about how to manage B12 deficiency. I've just put up some of the quotes that came from the woman. This one's being vegetarian, how it's part of the identity, so that was really important. Oh, the second quote down, but she's non-Brahmin, was in response to one of the women in the focus groups was B12 deficient in pregnancy, so a GP told her she had to eat meat. So she ate meat, but this was the response from another participant. And then the challenges to being vegetarian, trying to find out information on B12 sources of food. So after that I went on to Google and had a look. And there's a lot of contradictory information. Some of it will state that B12 is available in spirulina, tempeh, seaweed, which it's not a bioavailable form of B12, and some quite credible looking sites will actually state that. So these women are right, it is quite difficult to find the information. There was a lot about searching for answers. I had a number of these where women had been on B12 injections for years, and what would happen is they'd have their B12 injection and their levels would go really high, and then because they didn't have a problem with malabsorption, the levels would stay high for quite a number of years, and then they'd start to drop down again until the woman got low. So they were seesawing with their B12s, and so they were questioning why the injections, and also why it was happening. And then there was another woman who just decided she would do something about it for herself. Now she got her tablet from India, but B12 supplements are available, cyanocobalamins, in the supermarket, in multivitamins, and in the chemist here, and in health food shops. So the next phases were the quantitative phases. First of all, the development and validation of the vitamin B12 food frequency questionnaire. Now in this questionnaire, I only focused on foods that contain B12 in order to make it a reasonably short questionnaire, and I think it still ended up being 6 pages. This was tested on women when they were first recruited in the study, and then their estimated B12 intake was compared with biomarkers of B12 status, the serum B12 and the holotranscobalamin, to find out how accurately we could predict B12 deficiency from this food frequency questionnaire.
Can I ask another question before we move on?
Yep.
You talk about women being vegetarian, and I understand particularly the issues around not drinking milk in these cultures, but I'm getting the impression that more of them are vegetarian and vegan. So they're still getting B12 in their diet.
They are still getting B12 in their diet, but not a lot for some of them. Some of them were absolutely fine. Their milk and yogurt intake was enough, and it tended to be those, I think from North India, tended to have a high consumption of, or originally from Northern India, of milk and yogurt, and those from Southern, not quite the same emphasis on milk and yogurt. It wasn't just the women that were vegetarian that were low in B12. Some of the ladies or the women in the study that were low in B12 were those that specified they were meat eating. I think the woman with the second to lowest serum B12 did state she ate meat, but she had really low B12 intake. So some of the women who specified vegetarian dietary preferences were fine with their B12s. Yeah. The randomised controlled trial, we compared 3 treatments, and we looked at the effectiveness of the treatment. We looked at how acceptable it was to the woman, and we measured that by persistence, and then how sustainable it was over a 6-month period. The 3 treatments were dietary advice to increase B12 intake, and because of the information from the focus group, we based that on foods that women prefer to eat. A 6 microgram B12 supplement, which is quite a low dose supplement, and then a placebo. And the supplement and placebo were prepared by a pharmaceutical compounding company to be visually identical. They were made so that I couldn't tell the difference apart and the participants couldn't tell the difference. The first finding was that 44% of the women in the study reported an adequate intake of B12 on the food frequency questionnaire. And when we looked at across dietary preference group and how that related with serum B12, I've set these graph-ups just so visually you can see that. The green column are the group that ate red and white meat, and you can see that the median B12 intake is way above the recommended daily intake, and their serum B12 was sufficient. But for the lacto-vegetarian, which are the red group, the lacto-ovo-vegetarian, the blue group, the vegan, the grey group, and the women who ate white meat only, you can see that their daily intake, reported daily intake of B12 was below the recommended average, and their serum B12, median serum B12 was low. So the intervention study recruited in 62 women of South Asian origin with the 3 treatment groups, and it was powered to detect a mean difference of 66 picomoles per litre in serum B12 over 6 months. When the women were recruited in, we stratified them into 2 groups, meat eating and non-meat eating, and that was done so that we had an equal distribution of those that ate meat and those that didn't eat meat between the groups. So we had about 60% vegetarian in the study, about 40% non-vegetarian. And then they were randomly allocated into one of 3 groups, and we made the assumption that we'd have nice, evenly distributed groups in terms of baseline serum B12 and HOLO-TC. Yeah, right, we didn't. We ended up with the supplement group, the baseline serum B12 and HOLO-TC were considerably lower than the other groups. The woman was seen at baseline 2 months and 6 months. We took a variety of blood tests for full blood count, monitoring for anemia, particularly macrocytic anemia, HOLO-TC and B12, the 2 biomarkers, glucose and insulin, looking for insulin resistance, and then lipid profile. Took a variety of measurements and measured body fat percentage and fat-free mass by bioimpedance, blood pressure, grip strength to determine muscle strength, and then nutrition from the food frequency questionnaire. The first finding was B12 deficiency was common in the sample population. The baseline, the HOLO-TC and the serum B12 are the 2 biomarkers. On the left-hand side is the baseline HOLO-TC. The grey pie is those that are sufficient, so 59% of women had sufficient HOLO-TC, so that reflects the tissue supply of B12. 41% were insufficient. In terms of serum B12, 51% were insufficient at baseline. So it was a lot more common than we actually anticipated. Then we looked at the treatments over 6 months and whether they were effective. This graph here shows the percentage change in serum B12 over 6 months. The statistics were analysed using analysis of variance, and there was a statistically and clinically significant change. You can see the blue bar on the right-hand side is the B12 supplement group. This graph measures percentage change in serum B12 over the 6 months, and there was a 30% increase in serum B12 with B12 supplement group. So a good response, and that was statistically significant. The diet advice didn't work. There was a decrease, just a small insignificant decrease in serum B12 over the 6 months, and a decrease also in the serum B12 for the placebo. I did wonder if that was the effect, because there was a decrease in reported dietary B12 intake, if that was the effect of that increase in the cost of dairy products over that period. And this is just the same, really, it shows the same picture for that second biomarker Holo-TC, except there was a 39% increase in Holo-TC for that B12 supplement group. So that showed that the treatment was effective, that B12 treatment. So then we wanted to look and see if it was sustainable over the 6 months. So these graphs here show adherence for both the placebo and the 6 microgram B12 supplement group. The green columns show the adherence at 2 months. So what I would do was, when I went back to drop off another bottle of supplements, of capsules, I would count the remaining capsules. So it was a very rudimentary estimation of adherence with taking it, and just calculate the percentage adherence. So at 2 months it was over 80%, and the majority of women were taking the supplements, with the odd exception. At 6 months, and that's the blue columns, you can see that adherence had dropped off quite markedly for both the placebo group and the supplement group, and some women had stopped taking it altogether. When we looked at dietary advice, this shows the change in reported B12 intake over the 6 months. So the brown column is the baseline reported B12 intake, the green is at 2 months, and the blue is at 6 months. And what you can see is that it really didn't make a lot of difference to their B12 intake, the dietary advice. This shows the relationship. We then asked if adherence does drop off, does that affect the response in B12? And this graph shows the relationship between the change in serum B12 over 6 months and the percentage compliance. And I've put a vertical line in at about 75%, because that was the point at which if adherence dropped below that 75%, then response in serum B12 did drop off. It was a positive correlation. I undertook a Spearman's correlation because the statistics were quite skewed. There were some outliers there, so I used a Spearman's correlation, and that was statistically significant and a moderate association between the two. This looks at the correlation between taking the placebo and whether it made any difference to serum B12, and as expected it was a placebo, it didn't, no relationship. This graph is interesting. This is the B12 dietary advice graph, and we looked at the relationship between consumption of B12 foods. So if someone did increase their dietary intake of B12, did it make a difference to the serum B12? And according to when you look at the graph, yes, it did make a difference, but there had to be a reasonably significant increase in B12 intake to actually influence serum B12. So the correlation was still 0.6, it was a moderate correlation, but it did show that you need to really be quite effective with giving the advice and to make quite a difference to the intake for some of these women to really produce a change in serum and B12 biomarkers. And then I looked at whether the study interventions reverse the percentage of B12 deficiency. So this shows the percentage of B12 deficiency in the woman from the B12 supplement group. At the top is the serum B12, and the tan pie represents sufficiency. So this is where we had our different baseline starters. There was more women deficient in this group. So in the B12 supplement group, 33% of the women in this group only 33% were sufficient to start with. So 38% were borderline low and 29% were low. At the end of the study, we had a really good response. So 76%, or 16 out of 21, were sufficient in B12, and only a remaining 5 were either borderline low in B12. So we had reversed the percentage of deficiency in this group. Not quite the same success with the Holo-TC. At baseline, only 40% of this group were sufficient in Holo-TC, and by the completion of the study, 62% were sufficient. But it was better than the results we got from the placebo group. At the start of the study, 53% of the placebo group was sufficient in serum B12, and that dropped over the study, so only 47% at the end of the study. and the same with Holly. You see, it looks quite dramatic there, but when you look at the numbers, it was 10 that was sufficient to start with at the start of the study and 9 sufficient at the end. So it actually wasn't statistically significant. And a similar sort of result for the B12 dietary advice group. A slight decrease in sufficiency in the serum B12, but the homology stayed the same. So that showed us that the B12 supplement was effective in reversing B12 deficiency in these groups. We looked at some other risk factors for chronic disease. The studies that came out of India did show that, did highlight an association between B12 deficiency and insulin resistance, and B12 deficiency and raised cholesterol and adiposity, but I didn't find that in this study. What we did find, this scatter diagram here shows the relationship between body fat percentage and BMI. So it's a positive relationship. It's got a correlation of about 0.9, which is quite a strong correlation. The interesting finding is, for the woman, even the woman in the study that had a low BMI, so the lowest BMI in the study was someone that sat just below 18 of BMI, but that woman still had a body fat percentage of 46%. So what I found when I went around and measured, in fact when I took the bioimpedance machine and measured the first couple of women, I then went back to Elaine and said the machine's broken, I need another machine because it's giving these abnormal recordings. And she assured me that this has been the findings on studies that have been undertaken in people of Asian Indian origin, is that for a lower BMI there's a much higher fat percentage, which does increase the risk of chronic disease. In fact, the lowest body fat percentage in the study was about 42%, even though there was a number of women sitting between 18 to 25 on their BMI. I didn't find, this is the relationship between serum B12 and cholesterol HDL ratio, no significant relationship at all. And the same with serum B12 and insulin resistance. I didn't find a significant relationship between serum B12 and insulin resistance, but remember I only had 62 women in the sample, and the study was powered to detect change in serum B12 rather than to detect this. So maybe a larger study may be to detect the differences. So a summary of the main findings, the big thing out of the focus group was that the women wanted choices for prevention and management of B12 deficiency. They wanted to know what caused their B12 deficiency and what they could do about it. Borderline B12 deficiency was common in the sample population. The 6 microgram supplement capsule was effective for reducing the percentage of B12 deficiency, but adherence did drop off over time. Now I think we probably set the dose too low. What happened was it's quite a low dose, so when adherence dropped off, efficacy dropped off and it no longer increased serum B12. We would have probably had better success if we'd had a higher dose of B12 supplements, still within a physiological dose, maybe given less frequency, maybe 20 to 50 micrograms, maybe given once a week. So the women have got a whole week to remember whether they've taken their tablet or not, maybe more effective. So we need to follow that up. And the B12 dietary advice had an insignificant effect, but I think it was the way the advice was delivered. So we need to really look at effective ways to deliver that dietary advice to increase B12 intake. And then the other recommendations are a review of the policies. We currently fortify bread with folic acid, but there's no B12, or there's limited B12 food fortification. In Australia and States and UK, cereals are fortified with B12, and a lot of studies overseas have shown that that's a main source of B12 intake. For the South Asian woman, I'm not sure if that will be effective, but maybe we need to look at things like fortifying tofu that's overseas, that's fortified with B12, that isn't here, or maybe rice. Pharmac funding of an oral B12 supplement. Maybe the GPs prescribe the intramuscular B12 because that's cheapest for the woman. And there's no oral supplement, so we need to have an oral B12 supplement funded. Management of B12 deficiency needs to be appropriate for the cause. Closer monitoring for B12 deficiency in at-risk populations, particularly women preconceptually and in that early antenatal blood screening. and emphasis on adequate B12 as well as folic acid prior to pregnancy. So that is it. So just a thank you